Hello and welcome to Don't Tell Me to Relax, the fertility podcast here to guide you through the roller coaster of trying to conceive. I'm Hannah, your host, a fertility acupuncturist with clinics in London and across the UK. Our patients tell us how frustrated they feel about their lack of fertility education. So this podcast aims to provide all that education they never taught you in school, with the aim of putting you back in control of your fertility journey. We also have our fertility community to help address isolation and provide further information and support. To join us, the link is in the show notes. This podcast has been sponsored by FemHealth, a new online department store for fertility and conception. FemHealth help women embrace their fertility journey by providing access to products, treatment and resources. Fem is also home to Temp Drop, a new all-in-one device that you sleep in, giving you insights and valuable information on your cycle and fertility. Visit FemHealth at www.femhealth.co.uk with over 250 products and 60 brands to support your journey. Use the code RELAX15 for 15% exclusive discount. Hi, it's lovely to have you with us today. Welcome to this week's episode of Don't Tell Me to Relax. Today I am joined by Maria from Plan Your Baby, and we are going to be talking all about support for your fertility without doing IVF. And this has come off the back because somebody wrote into me and said, Hannah, have you got an episode on using ovulation induction and what is the process? What are the side effects? And I was like, no, we haven't. We need to do one. So I emailed Plan Your Baby because I know they are a clinic who specialize in the areas before IVF or the alternatives for IVF, and said, can you send someone to talk? So Maria, welcome and thank you for coming on and giving up your time to come and talk to us today. Do you want to tell us a little bit about Plan Your Baby and yourself and how you work?
Thank you so much. And Hannah, thank you so much for having me today. It's a huge pleasure and honor. So my name is Maria. I've been working in the fertility field for now more than 14 years coming. And myself and our medical director, we found Plan Your Baby just about 3 years ago. We're actually having an anniversary on the 8th of October.
Happy anniversary.
Thank you. And the idea was actually to help patients who can't afford, either financially or due to their business or work commitments, to go for treatment to a clinic that they actually prefer. And predominantly, we all know that private healthcare exists in London. But then if you live in Wales or if you're in Southampton or, somewhere in a much nicer place than London, it's quite often very difficult to find a clinic that would operate 7 days a week, would deliver same-day results, and on top of that, you would get the highest expertise as we more often get in London. So my medical director, Dr. Sami Al-Musawa, I'm extremely lucky to be not only just his colleague, but a good friend for many, many years. We said that, okay, there must be something else that should be, created for patients. And that's how we built Plan Your Baby, with now more than 350 locations nationwide, where patients can have access to all sorts of treatments. And the focus is to address 13 most common causes of infertility through the non-invasive approach. So we actually work really hard on addressing the diagnosis, the actual root of the problem, and then we tailor and finalize the treatment plan. And that's all based on the expertise involving perhaps different colleagues like embryologists, geneticists, nutritionists, acupuncturists, and combining all of our forces to come up with a plan and then help patients through the very tailored approach and medications to their cause. So how we can help without IVF.
I mean, it sounds so good because we often get people who ask us, well, for example, our fertility nurse on our team, she is up in Scotland and she is always pulling her hair out because it's so difficult for people in Scotland, if you're not in one of the big cities, to get good fertility care. And we get asked a lot of time, people who can't afford IVF or they don't want to have IVF or they can't access IVF, like, what else can I do? People often come to our clinic as like the last chance saloon. They're like, I've tried everything else. If there's nothing else I can do, I come and try acupuncture. And what I really like about your clinic is we like to work with Western medicine as well. We're holistic practitioners, but sometimes we know that bringing in some Western medicine alongside it that's not IVF can be one of the most powerful combinations that you can do. And I think this is particularly true around ovulation induction, because obviously we work a lot with
Yes.
people with menstrual cycle issues. So ovulation induction can be amazing. And can you tell us, first of all, what it is? What is, when I say ovulation induction, what am I talking about?
Yes. So, of course. So, ovulation induction is a treatment cycle of the months that you start a treatment, and you prescribe certain medications, for example, like Clomid, which we stopped using. We now prescribe more tamoxifen, letrozole. So those medications, like for example Clomid, it blocks estradiol receptors in the brain, and it gives more FSH to stimulate the ovaries. So it blocks actually the process, the conversion from testosterone to estradiol hormone, and therefore there is less feedback on the brain, and it pumps the FSH hormone, and then it helps to stimulate ovaries. It also can be called as multi-ovulation or cycle, so where a patient has ability to produce not just one follicle, but perhaps two, and potentially release two eggs to maximize her chances for conception. Now, also, the cycle, the treatment has to be, of course, supported with other medications, which are as important as letrozole or tamoxifen or Clomid, which I think patients, they know Clomid more than letrozole, so it's been very popular in the last 20 years. So it's the ovulation induction itself, the medication that will help patient to induce the follicle well, the process, so that it will help patient to release an egg. And then afterwards, it's extremely important to prescribe progesterone medication. So if there is not enough of progesterone hormone, then we prescribe progesterone medication to support the actual implantation and luteal phase. So it's quite tailored treatment plan, but it's it's prescribed by different clinics, different doctors, especially NHS, in a very different way. And this is where you find a huge difference, not only when you look at the success rates, but the treatment quality itself.
Yes. And this is the thing that we often see in our clinic. So can we just start with Clomid? And because
Yes.
this is kind of we've seen a lot over the years being used, but obviously, exactly as you said, it's been used less. Can you tell us why it's been used? Like, why is that being phased out more? And is Clomid still used like in NHS clinics? Like, tell us about what's happened with Clomid.
Yes. So Clomid historically has been prescribed by the GPs. Okay, so that's how it all started, to help patients to achieve the pregnancy. GP doctors, they had ability to prescribe medications, for example, from 3 to 6 months, but without any monitoring. Now, and that's where the patients were left in completely darkness. And some of the patients, they had 3, 4, 5 follicles that resulted to a multiple pregnancy. And that was one of the biggest concerns, that if you don't monitor the cycle, then you eventually either cause more damage rather than, helping patients out to achieve the pregnancy. And then obstetricians and fertility specialists started to prescribe Clomid. And now different clinics, including NHS fertility units, they prescribe Clomid in ovulation induction cycles. And very often you see that patients are asked or given opportunity to try for at least 6 months. But again, you have to look at how exactly the medication is used, because without monitoring, it loses this unique opportunity for patient to achieve the pregnancy, because it's not just enough to give the Clomid. Now, of course, it's also important to understand why we have shifted our attention from Clomid to other medications. We've used Clomid for many, many years, and what we've noticed that Clomid has quite negative feedback on the endometrial lining. So, because we monitor our patients quite precisely, after you prescribe Clomid, it's given for perhaps 5 days only, We perform the ultrasound scan and the blood test together around day 10, 11, 12 of the cycle, depending on the length of the menstrual cycle. And we check the activity of the ovaries by looking at how many follicles patient has, the size of the follicles, and also the endometrial thickness. So one of the side effects what Clomid is giving, it's blocking the estradiol receptors in the lining. What letrozole and tamoxifen does much less, so you don't see this side effect that often. And what it results to, if the lining, endometrial lining, is thinner than it's supposed to be, and we are talking about 4-5 millimeters, rather than in a normal cycle, usually lining can get to 7.5, 8, 9, 10 millimeters. That's the environment where embryo will implant eventually. Now, and if it's too thin, the vascularity also is not there as good as it's supposed to be to support the implantation, and therefore it can result to a failed implantation, and that's why one of the, I would say, the biggest reasons why we have stopped prescribing Clomid.
Okay. And can you tell us, when you say cycle monitoring, what do you mean, and how frequent should a person expect to have cycle monitoring if they're doing letrozole?
Yes. So I can explain you what we do, but
Yeah.
not necessarily other clinics doing the same. What we believe is resulting to a good success rate is the quality of the monitoring. Now, when we see the patient, of course, we have to ensure that semen analysis is fine, and we can actually give them the medication to perform ovulation induction cycle. We do the blood test, a full hormone profile, including such hormones like FSH, estradiol, progesterone, prolactin, and progesterone. So we look at the hormones between day 1 and 3 of the bleeding, and we also perform the ultrasound scan. Now, the reason for that, it's important first to understand if the actual cycle is suitable to prescribe medication and start the cycle or not. Because sometimes we have some cysts that we form, sometimes, especially for a patient's maybe with a lower AMH results, the hormones start to fluctuate at the beginning of the cycle. And that results to either very high estradiol level or very high FSH. And that can affect the outcome of the treatment. Either patient will not respond on medication, or if there is a cyst, by giving the letrozole or tamoxifen, we may just stimulate the cyst itself rather than a follicle. Now, and then when we prescribe medication, usually it's given for 5 days. Some patients with some severe polycystic ovaries, we may give for 10 days, but again, it's the matter of medical history. We then perform ultrasound scan around day 10, day 11, depending again on the patient's ovulation or how long is his cycle. We do the scan, we do the blood test on the same day. Now, and what is extremely important is to get the results the same day as well. Because if you get the results 3, 4, 5 days later, that's just going to be irrelevant anymore because you're not going to know what's happening. So we do the bloods and the scan, again, to check the thickness of the lining, because this is the moment where we can prescribe some other medications to boost up the endometrial thickness. And we can talk about this in the next question. A lot of clinics say they don't prescribe any additional medications to support the cycle, just the Clomid. So we assess the follicle sizes, we correlate it together with the blood test, and then we make a decision. If we see that the patient is ready and the follicle is quite decent sizes, for example, when our body is ready to ovulate, the follicle can be anything between 17 even millimeters, 18, 20, 21, 22. So by assessing during the ultrasound scan, we see how ready patient is. And then when we see that the blood test is actually not there, and the LH hormone that is responsible for ovulation to actually luteinize the follicle so patient can release an egg, if it's too low, we have to prescribe a medication. And again, it's very time sensitive, so we have to prescribe it right at the moment when we should, so patient can release an egg. And then we monitor the progesterone. So we do the blood test about 5 to 6 days later after we prescribe the ovulation induction medication, the trigger shot also it's called. We check the progesterone test. We'll look at the progesterone, how high or low it is. Again, according to our expertise, we prefer to have progesterone slightly on the higher side rather than under prescribing, because we believe, and we notice that very often, that progesterone fluctuates and drops after the implantation window and during the luteal phase before either the next bleeding or at the moment where we can perform the pregnancy test. So it is a very, very tailored treatment, and we monitor the hormones and bloods and the scan only based on how actual patient performs, rather than something that perhaps you've heard so many times: do progesterone test on day 21. And this is not true. It's so outdated. The progesterone test needs to be done exactly 5 to 7 days post ovulation, but not on day 21.
Yeah, we have so many people in clinic who've had it done on the wrong day. It's
Yes.
very common. So can you tell us, Maria, who would this kind of treatment, this kind of cycle monitored ovulation induction, who would it be good for? Like, who would you recommend tries this as an option?
Yes. So I think what is the most important is to assess the medical history, and then to understand, first of all, for how long couple, tried to conceive. Either it's just a couple of months or it's been a year or longer. It's important to understand as well any past infections. And we also have to do some baseline checks before we even prescribe medication. So for the men, it would be at least semen analysis. Maybe there will be a severe male factor where ovulation induction will not be a suitable treatment, and for some severe male factor like azoospermia or extremely low sperm count, or there is zero normal forms. Unfortunately, the IVF would be the solution, perhaps, or referring to andrologists to review that. Now, for the female, we do some checks like hormone profile, ultrasound scan, sometimes thyroid as well, and assessing fully medical history if a patient had any infections, to understand if we actually need to check the tubal patency to ensure the tubes are not blocked, because that would be the game changer. If the tubes are blocked, we're not gods. As much as we would like to help, we won't be able, at least with ovulation induction. And yes, and the patients who perhaps suffer from polycystic ovaries or polycystic ovarian syndrome, we just recently assessed all of our cases, and 66% of the patients, they have polycystic ovaries or polycystic ovarian syndrome, and they've been advised IVF, but they come to us and they achieve pregnancy within the 3 or less cycles. Patients with a low ovarian reserve as well, they also benefit from this treatment, because not always IVF is the solution when they produce 1 or 2 eggs only. And if there is no male factor, and actually if the ovulation induction treatment can be supported by more tailoring approach. So for example, not necessarily it's just going to be letrozole prescribed, but we also prescribe all sorts of medications, and it can be even immune treatment, even blood thinners, depending on their condition and medical history, and someone who perhaps had miscarriages in the past. So that also needs to be taken into consideration. Also, patients who are young, but they have tried for a while, the pregnancy didn't occur within the year, and they went to GP. They were told everything is fine. So either you continue trying or you seek help. And this is where perhaps ovulation induction may be helpful, because for those cases we see in our statistics that it's enough just 1 or 2 cycles and they achieve pregnancy if there is no any obvious cause for them not being able to achieve pregnancy.
How often do you do tube checks? Like, is that so? When you say tube checks, that's like a hycoxy to check the health of the fallopian tubes. How often do you do that? And can people do that all over the country through your clinics, through your partner clinics?
So hycoxy, it's we don't do it routinely for absolutely everyone, because we find it unnecessarily, and it's not the most pleasant procedure, I must admit. it's quite painful, and some patients just can't tolerate it. Now, what also we have to remember, by doing the procedure does not mean we will have an answer. That's number one. Number two, sometimes the tube can have tenderness, and the occlusion might happen where the actual tube is not blocked, but due to sensitivity and the actual uncomfortable feeling, it can narrow down. And then the report will tell us that it's blocked, but not necessarily it is. Now, we assess the medical history. If patient never had any STD infections, especially chlamydia, that's the nasty one that can damage the tubal tissues, and especially if it's been left untreated for a long time. So if the medical history shows that there were no signs of infection, we would try maybe once or twice with the cycle, with the treatment cycle. If there is no success, then we would offer the procedure. And we had many cases where patients had pregnancy, and we didn't need to do this procedure. Now, it's not very cheap. It's cheaper, of course, if you compare to other investigations like hysteroscopy privately or IVF itself. So the price with us is £560, and you can do it in a few locations in the country. We don't offer it in every city because we don't have medical practitioners who has expertise to perform this procedure in a quality manner. But we have in a few cities where patients can be referred to and do the procedure with no delays and no waiting list.
Mm. It's interesting, isn't it? Because I often wonder, like, well, it'd be interesting to hear your thoughts. How many times should a person try ovulation induction before they move on to something else? Like, I know there's probably no magic number, but what are your kind of recommendations of how many times to try ovulation induction?
Very often, if patient is younger than 36, 37, we would recommend more than 3 times, because every time when we perform ovulation induction, and for example, if it does not work, we review what can we do differently. We don't like to have the same protocol for 6 times and nothing will be changed, because that just doesn't make sense. You have to understand, okay, maybe we should change medication. Maybe we should change the dose. Maybe we should add some additional medications to maximize the chances. Now, and that's for the ladies younger than, I would say, age 37. Now, uh, patients who are older, on the older side, we have to be, of course, very cautious. And the most important for us as clinicians is not to harm. And the time is one of the factors. We don't want to waste their time if we feel that they've never done IVF before, they haven't tried. They've tried a few times ovulation induction, for example, 3 or 4 times, and the treatment can be done with no breaks. And then we can move on to IVF. For someone on the older side, I would say 39, 40 plus, we wouldn't advise to try 6, 7, 8 cycles, because we have to be really cautious about the time and understand maybe the further investigations needs to be done.
Mm. And are there any side effects from taking the letrozole, like or the ovulation induction medication? Do people tolerate it well, or what happens?
So I would say the most common what patients experience is the headaches. The nausea, mood swings, and sometimes muscle pain as well. That's the most common. Sometimes it's a breast tenderness as well. And usually the side effects would go away as soon as patients stop medication. So we always advise them to drink plenty of fluid, water. It's at least 2 liters of water during the time while you're taking those medications, to make them feel better and tolerate medication better. Then I would say that's the most common. So we haven't witnessed any severe side effects rather than this. But usually they go away quite quickly as soon as patients stop medication.
So it's not, and I mean, I know this from supporting people in my clinic, it's not as invasive as IVF, and it's not as all-consuming as IVF. I mean, obviously you have to go for scans and you do have to take the
Yes,
medication, but it's not as full on, I would say.
it's absolutely not. It's not as full on. And IVF with us, we also offer IVF. It's very, very tailored and very close monitored. Our patients, they have blood tests and scans every other day, and closer you get to trigger shot egg collection, it's every day sometimes. So it's a very, very close monitoring, and the ovulation induction is nothing like this. Of course, when you have IVF treatment, the medications that you will be prescribed are completely different. And first of all, it's an injections that you have to perform on a daily basis, and sometimes it can be 3, 4 injections every day. And then the side effects and the risks that patients have to understand that can occur. It's by far the most probably scariest is overstimulation, the hyperstimulation, and it can be life-threatening. And that's why we monitor our patients so precisely that we completely almost eliminate the risk of hyperstimulation. We adjust the medication dose every day, every other day, just to avoid patients being, at any risk. Still can happen, but it's not nothing to compare with some units. We have the 10% of all of the cases they perform, they end up in the hospital, which is quite scary. And of course, during the IVF, it's the actual procedure that you have to go through. It's the egg collection and the embryo transfer, and some risks like, perforation, bleeding, infection. So you also have to consider those risks. Not happening that often, but can't be left without attention.
And we get asked this question a lot. When somebody's doing an ovulation induction cycle, what is your advice of how can they prepare? How can they
Yes.
optimize? What can they do to improve their chances either before or during their cycle?
I really like this question because for me, it's the most fascinating what can be done to completely change the whole scene and picture for the treatment and the outcome. We absolutely should not underestimate the power of healthy lifestyle, the diet, especially for polycystic ovaries or polycystic ovarian syndrome. The special diet is very important. We need to make sure that we more or less will have a healthy BMI, because that also can affect the ability to achieve the pregnancy, to carry the pregnancy. Then it's a little bit of sports, always healthy, not too much, not heavy lifting, you know. But even this can happen, but we have to be cautious. But a little bit of sports, no smoking, no drinking. That's something that we definitely would advise. Supplements and vitamins, very important, and some vitamins can play some role, like for polycystic ovarian syndrome, metformin. We do prescribe some medications that can improve the quality of mitochondria. It's like ubiquinol or CoQ10. Folic acid is very important. Vitamin D is very important. The whole group of vitamin B is important to take. Can be taken as just a part of multi supplements, multivitamins. Also, what we started to very carefully look at is microbiome. And this is something that is a huge topic right now. We have started to work with one company, and we have seen cases in our practice. They did not have a pregnancy at all in their life, had IVF treatment, didn't work. They came to us, and we did a microbiome test. We adjusted their lifestyle, we adjusted their medications, etc. And patient got pregnant within the 4 months. And now pregnancy is well progressing. She's past 15 weeks, and touch the wood, fingers crossed for her. And we had a few cases like this, and I think this is going to be a huge topic because relatively it's very affordable test. Some companies offer it on a more higher scale, but the test can be done even for under £100, and it will be very good quality. And to address the microbiome through the probiotics. Sometimes, in some cases, can be antibiotics, but it can make a difference. Can make a difference. Also, acupuncture. This is something that we advise to our patients as well.
I've not
And
paid you to say that.
yes, I can confirm. I can confirm. We do have a lot of patients. They have acupuncture before to start treatment. We advise to have it during the actual cycle. For IVF patients, it's a bit different. There is a bit more tailored, I would say, protocol. And patients, they have acupuncture on certain days, and they have acupuncture before the embryo transfer and straight after embryo transfer. Um, I wouldn't say we have patients who had it during the pregnancy, but during the actual conception, preconception to prepare themselves, they do have sessions. Um, Now I'm thinking, what have I forgot to mention? But overall, these are the steps that we definitely would recommend and would advise patients to look at before they start.
And before we go, I've got one more question, because the number one question that we get asked
Yes.
is, and you know, we've done a lot of podcasts about it and a lot of webinars, is around only progesterone support, because we have lots and lots of people who get in contact with us asking us about, you know, they think they've got a problem with their luteal phase.
Yes.
They feel that it's too short, or they've got lots of spotting, or their period is not quite right. And so is it possible to have progesterone only support, or do you only do progesterone support alongside ovulation induction?
It's a very good question. Okay, I guess we perhaps see from all of our patients, I would say 20% are coming just for progesterone support. Now, Plan Your Baby actually is the clinical partner and the clinic behind the product called Proof. It's the progesterone testing kit that you can buy in pharmacy, online, different platforms. And we have a lot of patients who are coming to us with their results asking, so what do we do? So we have tried everything. We're not ready for IVF, or we've tried IVF multiple times, and it's expensive. And emotionally it's too hard. We don't want to try this. Or if they've just started with some investigations, and they've realized that, yes, as you said, either they've noticed the luteal phase is too short, or perhaps they start to have some bleeding from the ovulation moment, and when they're expecting the pregnancy test to be positive, and maybe they've seen some spotting or bleeding or some symptoms, or they've done the test and they confirmed, okay, progesterone is too low, and it's not a one-off, it's a recurrent problem. Yes, and it can be addressed, absolutely. We do like to check a progesterone test to confirm exactly how low it is, and then we prescribe progesterone. We prescribe it for 12 to 15 days. Then we ask patient to do the blood test. So usually patients would start progesterone from, depending again on their medical history, but between day 3 or 5 post-ovulation for 12 to 15 days. And we do start with non-invasive medication, or let's say non-injectable progesterone, which is it's suppositories. And then we would advise them to continue progesterone up until 12 weeks. So that's something we would advise them to 12 weeks of pregnancy, not to stop it as soon as they see they're pregnant, because that will be crucial to continue monitoring and to monitor the pregnancy itself and to look at the levels. Now, what we see very common, and we do this monitoring for our IVF cycles. So when we transfer an embryo, we start to check progesterone every other day until we do the pregnancy test. So this is something that you will not see almost only one clinic apart from us doing this. That's it in the whole country. So we check the progesterone now, and what we've noticed, in 80% of the patients, the progesterone drops. And many reasons can be for this, and some of the reasons really needs to be addressed with other supportive medications, and it can be autoimmune conditions that actually, and some certain cells that works against the implantation, against the hormones. There will be some antibodies produced by the body, and therefore the progesterone will start to drop, and we see significant drops. Now, the idea behind this to check the progesterone is to address this drop and to prescribe the correct dose of medication. So we do look at the levels, and some patients, they require injectable progesterone. And it's also something that we offer, progesterone support, we offer pregnancy monitoring. So we work with a few communities, charities. They support patients who suffer from recurrent miscarriages and who, who had pregnancy losses at different stages. We support those communities, and we see their patients when they come to us. We monitor their pregnancy. So we would start to monitor them right the first moment they found out they're pregnant. And then we monitor the most crucial stage, which is the first trimester. We do frequent blood tests even before they get to 6 weeks of pregnancy. So we monitor beta HCG and progesterone to address the levels and to see how exactly the pregnancy progresses. And it tells us really a lot, and it allows us to change their medications during the pregnancy. And then once we do the first ultrasound scan at 6 weeks, we do ultrasound scans about every 7 to 10 days until they get to 12 weeks of pregnancy. So, and again, we monitor progesterone every time, because we have to look what's happening with the levels. And the placenta will not actually complete this function until it will be formed fully. So the pregnancy still has to be supported. That's how important is
Yeah.
progesterone. Yes.
It's the super hormone. So Marie, can I ask, so if there's somebody listening to this, let's say there's someone listening to this in North Wales, okay?
Yeah.
And they have been to their GP and they've had a day 21 blood test, and the GP has said to them, your progesterone came back, it's absolutely normal, no further action. And they are somebody who maybe they spot from day 22, 23 of their menstrual cycle, they spot, and the spotting slowly gets heavier. And so they they feel really like there is the endometrium is coming away too soon. There's no opportunity. There's no other issues. The sperm test is fine. They're ovulating okay. They know they're ovulating. How can that person access support through you for their progesterone? What would they do? Like, what would be the process?
So the beauty of Plan Your Baby is that you don't have to come to London to see us.
Yay.
It's very simple. It's a game changer. And we have patients from Wales, and we have a lot of them.
Yeah.
Because Wales is probably the most difficult region. Just don't have enough practitioners or clinics who can provide you this type of care. So the easy steps that patients need to do is to either book a free 15-minute call with us, so we can answer all of the questions before they commit to speak to doctor. But then the next step is to book a consultation online, either on our website, and to speak to a medical director. Doctor will review the medical history, will review all of their previous results, and will make a plan. And then we give patients an option. We either can send the medications with the next day delivery through our partner pharmacy. We also try to work really hard, so we provide a 15% discount on all of the medications, regardless of what medication it is. We provide 15% off, and then patients they get medications the next day, and we start to monitor the bloods. Exactly. So we would ask them to use ovulation sticks if they work for them. If not, we will perhaps need to do a bit more invasive with a blood test to understand when exactly is the ovulation coming. Then we would do progesterone test. Sometimes, in this specific case, we may even do estradiol together. And then we would prescribe the medication to support the progesterone hormone. And then again, doctor will make a decision regarding the dose based on the case to case, because some severe cases really would require closer monitoring, and someone with less obvious, I would say, symptoms. For example, the case you've mentioned, the bleeding, and if we know that the endometrial is thin, so there are other things that needs to be done to support the endometrial thickness, the hormones. We will need, even sometimes we prescribe estradiol tablets as well to those cases. And the fun fact, we also prescribe Viagra.
Oh, yes.
For females. Yes.
Yes,
It's
for
also another
linings.
Yes, it's also another magical drug that can help to boost the endometrial thickness, and it works well. It works really well.
Yeah. That is amazing. That is so helpful because it is. I know lots of people. I mean, obviously we're a practitioner based in London, so we have lots of places that we can refer to. But we have practitioners, fertility acupuncturists who work all over the country.
Yes.
And for them, they really struggle of supporting their patients to get the medical interventions and support that they need without going to a fertility clinic. It's like I always talk about the grey area between
Yes.
your GP and your fertility clinic, and there's this space, and I feel like as fertility acupuncturists sometimes we fill it, and we are obviously not medical, we're acupuncturists, and so what we love is finding ways to help our patients access that medical support that can make all the difference before they end up in an IVF clinic. And some people go to an IVF clinic and that is absolutely what they need to do, but it's
Yes.
it's that journey straight from a GP to a IVF clinic sometimes feels a bit, I don't know, like, hang on a minute, but lots of people are like, well, how did we end up here? We've not, we've not done other things. So it's really brilliant to speak to you and hear about how you're kind of also working in that space, because it's a really important space, I think, to work in for people across the country.
It is, and we've done a huge job. In the last 8 months, we've done more than 1,203 consultations.
Wow.
So we've spoken to enormous amount of patients to hear their pain. What exactly is that worries them? What they need, and where is the problem, and what kind of treatment they're looking for. A lot of patients, they did not know about even a single option rather than IVF, and that surprised us so much. But when you ask them, would you consider, the answer followed 100% yes, because IVF, it's emotionally quite hard process. It's financially very expensive, but then also the commitment that you have to make to travel, and it puts a strain. It puts a strain, and never mind that infertility itself, it's a huge, I would say, emotional will that patients are in together with their partner to continue finding, the reason, like, not to argue, still listen to each other, help each other, support each other, and this is the time where they need the most support, rather than consider them as a unit, and then I'll just offer them an IVF. This is not what it's about.
Yeah.
And yes, and we really heard some incredible stories, and eventually then patients came to us, and some of our patients were invited to celebrate with us our anniversary.
Oh,
They were so grateful, of the help that we've provided. So that's really heartwarming.
yeah, it is. Absolutely, it is. Maria, thank you so much for your time today. I really, really
you.
appreciate it, because I know this episode will be super helpful to so many people. So I'm going to put all the details for Plan Your Baby on the show notes so everyone can access it.
Thank you.
And yeah, thank you again, because that was absolutely cracking.
And thank you so much. Yes, it was my pleasure.
We hope you have found this episode helpful. If you'd like to leave us a review, we would love you to bits. And if you'd like more support for your fertility, you can come and work with us in clinic. We're based in London and around the UK, or you can work with us online. For more information, see the link at the end of the show.